Thank you for this invitation and for giving me the opportunity to speak today. Our goals and objectives today are a discussion of some of the challenges, frustrations, and barriers to living with epilepsy, some opportunities for audience participation and kvetching, recognition, and some solutions to some of the barriers to living well with epilepsy, and hopefully we'll end a little bit more optimistically. So one question is what does it mean to live well with epilepsy? What are our target goals? And from a medical model, we have target goals for other things. For diabetes, if we have diabetes, we want our hemoglobin A1C below 6.5, maybe 7, maybe 8, but we have a target goal. This is where we should be. For all of us, hopefully our cholesterol is less than 70, maybe 100, or maybe even 115 if we're like 80 years old, but there's a target goal. If you are paying for your children to go to college, hopefully, as they say at Temple, they fly in 4, they complete the process in 4 years. And as a homeowner, hopefully your hot water heater lasts 8 to 12 years. We're not always successful there. So when you think about target goals for living well with epilepsy, it's a little bit more complex. It's a diverse disorder, so goals for a given individual might vary. Some things that I think we might all agree is that being seizure-free is important, having no side effects, being able to work, to drive, to go to sleepover summer camp, to have no problems with memory, which is a problem for everybody, even if you don't have epilepsy. Medicine that is affordable, those are all target goals. So before we go on, is there anybody else who would like to share a target goal that is not on this list? Anything else? Yes?
Getting from point A to point B without having one.
All right, so being able to travel in the community, not have a seizure, to get there safely. Anything else? Yes?
Being accepted by other people when you have a seizure.
That's very important, right? Stigma, recognition, and misinformation. All right, thank you. So medical care is an essential cornerstone of epilepsy care. And many people manage a lot of issues in their life without ever seeking a doctor, right? Maybe they manage weight and blood pressure with exercise, but medical care is absolutely essential. And so one question that comes up is, do you like your doctor or your care provider? And often people say, well, this is the only neurologist or care provider that's either in my plan or in my neighborhood. But you have to ask, do I like my doctor? Does my doctor listen to me? Does my doctor listen to me enough? Can you get to the clinic? And that's a really big issue if you can't drive. Can you afford the visits? And so I can tell you that I see some seniors and their copay to see me is $50. That's a lot for a senior, right? You can do a lot with $50 if you're living on a limited income, right? I mean, it's cash money. For a retired person, and if they need to see me 3 or 4 times a year and they've got the cardiologist and 2 other doctors, that's a lot of money in a year. So sometimes you need to be able to speak up to say, Doc, I can't afford to see you that often. And then the other issue is, can you feel that you could speak up in terms of issues in affordability? And once upon a time, patients and doctors never talked about it. You know, here's the script. And you would have felt, oh my gosh, can I ask, what's my copay? Can I afford it? And often people have really not called us when we could have maybe fixed the problem of affordability, either for the doctor's visits or the other out-of-pocket expenses. Some of you will know that you have a copay for the year, right? So we're in 2018. If you get a test before the end of the year, it might cost you less than 2019 when your deductible starts out again. So all of those are important things, and people should feel empowered to talk it over with their care providers. It's not easy to be a neurology patient. The average wait time for a new appointment is 30 days. Now, I'm going to ask this audience, if somebody was newly diagnosed with a first ever seizure, how long do you think they should wait to see a neurologist?
Not so long.
Not so long. Give me, how many days, how many weeks?
2 weeks.
So 2 weeks. So we polled our medical students, and they think that they would agree with you that 2 weeks, that if you've had a first ever seizure, you should be in to see the doctor within 2 weeks. So for you guys who are epilepsy warriors, if you hear that from somebody, tell them, make a call, reach out. Somebody should know that they have to work on the system, get a hold of somebody. Those of you from the pharmaceutical industry would know that you just talk to Wilma in my office and she puts you in, right, somewhere in the schedule. The average wait time for a follow-up is 20 days, but if you've had a seizure and a seizure-related problem, you fell and you fractured your shoulder, 20 days is a little long as well. Some other things that this audience could certainly speak to is that general neurologists might not be as adept to the nuances of complex epilepsy. So it wasn't until you went to the epilepsy specialist that they told you, no, this and this, and this and this, and a lot of other things. It's important to make a good connection with your doctor. And so the right doctor for a given person might not be the right person for somebody else. So for example, for a young woman who's just learning to deal with epilepsy and a lot of other things, she might prefer a female doctor, but only 33% of US neurologists are women. The mean age of physicians is 51. So if you're a young person with epilepsy, having a doctor who's 72 might not enable you to really talk about what's going on in your life. That might be a fine doctor for you some other time, but it might not be the doctor for you when you're 23. And then only 70% of all neurologists are actually trained in the US. So things that are like my medical students learn that aren't just neurology, like to take a sexual history, to ask open-ended questions, to make a person comfortable sharing really important things. That doesn't necessarily happen if somebody's trained internationally. It doesn't mean that they don't have a great fund of knowledge for neurology, and they did do a neurology residency and fellowship, but the other things might not have happened. They might have been trained in another country where asking X, Y, or Z is taboo. Whereas here, you'd want somebody to ask you, or to ask a family member, are you drinking heavily? Is that why you develop seizures, right? So a little bit of a difference there. And then the other issue is that primary care doctors are the gateway often to get to the neurologist. And some aren't comfortable with epilepsy or neurological problems, and some just really don't have the time. And the actual medical term is patient-focused care. Like, that's actually a medical term. But it means like helping you develop a treatment plan that is specific to you, the person who has seizures. And it's important to realize that it's okay to make change, it's okay to speak up, it's okay to switch doctors. In our practice, we've even switched patients. We've often, maybe I have a patient and I can't get them to change behavior to do X, Y, Z, so I might have them work with one of my younger colleagues where maybe there's a better connection. And again, it's okay to talk about money, about the expense of things, about family and personal commitments. I might have somebody who might have an 80-year-old lady with epilepsy, and her granddaughter has to bring her, but it's her first job, and the only time she can get off is Wednesdays at 4 o'clock. And you have to sort of recognize that to say, well, we don't usually see patients Wednesdays at 6, but this is the only time grandma's gonna get here because the driver can't come any other time. And now, is there anybody here who would say that they don't use the computer or a smartphone ever? Or they're uncomfortable? Few people are uncomfortable using technology. And we at Temple, we have many people who are really uncomfortable using technology. The younger generation, right, you guys all have your smartphone, and you could show me how to do things that, and you could tweet that this is happening right now at the Epilepsy by the Epilepsy Foundation, but older folks often are reluctant to do that, and actually teaching people to do that can really have a big impact. We have an electronic patient portal, among other things, which works sometimes and doesn't. This is one example of many, but many practices have them. You can send an electronic message to your doctor. So if you work every day from 7 a.m. to 7 p.m. at 10 o'clock at night, when you realize that you need something, you can send them a message. Hopefully it gets through. And one thing about patient portals and all of this technology, so for our younger folks, We're using a lot of technology. We use an electronic medical record where we type everything in. We use the patient portal where the person can send us an electronic message that is HIPAA protected and only goes to your care team and is only for you. But sometimes it doesn't work. And so if you've sent your doctor a message but the doctor doesn't answer, sometimes it's important to make a phone call. And the other aspect of it is in the patient portals, we can send, or in the electronic system, the electronic medical record, we can send prescriptions. So often we send a prescription to your pharmacy, right? We've done it, we've pressed send. You go to the pharmacy and they say it's not there. They say your doctor didn't send it. We really did send it. It all gets lost. She's nodding. It's a huge source of frustration. I have to say it happens to me. My 92, almost 93-year-old father lives with me, and I'm like, "Where's your medicine?" He goes, because it didn't come. So I call the prescription thing, and they say the doctor didn't send it. Well, it turns out that he'd been out with his granddaughter in her car, and he put the medicine in his walker in the little pouch, and it fell out, and it was in the trunk. So the pharmacy plan said, nope, doctor never did it, don't have it, we had it all along. But if we hadn't found it, they would have left us with the impression that the doctor didn't do it. So it's really annoying, but it happens to everybody. It's nobody, and so sometimes, we just have to figure out where it is, and it's, everybody's well-intentioned, but all these electronic pieces don't always fit. All right. Now, if I haven't lost you all in a dismal outlook, one thing that happens to everybody is that insurance companies just say no, and they say no to everything. And we need it, and in fact, there's a session here today, and there are a few vendors out here who actually have information about the process for pre-approval for their products or medicines. And so you come to the doctor, and the doctor says, I want you to get a medicine or a test or epilepsy surgery, and we send it to the insurance company, and they just say, denied. And it happens to everybody, and it's nothing personal. And tests and medicines are denied for people with all kinds of medical condition. The insurance company often throws your doctor under the bus, and I also see this from my office staff, and they say your doctor didn't send the paperwork, or the paperwork's blank, or it doesn't say you have seizures anywhere, and it really does. And the other aspect of it is that the people on your care team, right, so your doctor, the coordinators, you want all those people to have skills, to be growing skills of being nice, to have empathy. But the skills that they need to deal with the insurance company are usually like the skills that you would need if you were under attack. So it's this dichotomy of having people who can just hammer into the insurance companies or say you're wrong, or did you read line 12? That's complete. And so it is an interesting dichotomy. And in terms of other things, like everybody has the slide set, but and we're covering this in one of the workshops if you're not attending, but I found on the Complex Child website the 9 steps to appeal an insurance denial, which hopefully your doctor's office does for you. But it kind of goes over all the things you need to do. Often, if they're denying for you and you're the patient, one thing to do is to have a family member help, because it gets to be so overwhelming and your emotion starts to override. It's like all the bad words that you know are just rising to the top, and you actually need somebody who has a little bit more level head who say, you got to read this part or take a deep breath or figure it out, because it's so incredibly, you get so wound up with it. So having a family member who helps you, not because you can't do it yourself, but just because you're just angry beyond belief, is helpful. Another thing to remember with epilepsy is to ask, or to be knowledgeable about, is who is on your care team. So hopefully if you're going through this, you have a care team, and that should include your family, your friends. It might include your coworkers. Some people never share with their coworkers that they have epilepsy. Teachers, and teachers at all walks of life. I have college students with epilepsy who never thought that they would tell anybody, but their professors have been so supportive and really gone out of their way for them. Your clinical team, so your doctor, your nurse practitioner, physician's assistants, the whole office, the Epilepsy Foundation, and of course the Philadelphia Eagles, in case anybody went to the tailgate event in the cold last weekend. So it's nice to know that we have a good set of people who are helpful and supportive and are on your team. You also want to recognize who is not on your team. And so some people are just ignorant about epilepsy and they need education. Sometimes you don't really, you feel like, why is that my problem? Some people have bias and they need education, but sometimes you feel like you don't have the energy to educate them. And sometimes if it's a work-related issue, you can call Sue, and she has talked to so many employers and office managers to kind of get them on board, because you really feel like, I need them to hear it from somebody else who is recognized as knowledgeable in their field, even though it's easy enough to find out. And sometimes you just don't have the energy to straighten them out. Some people are well-meaning, but they should think before they speak. And some people are just not nice, and you should just take them out of your list of people that you share with. And then I found this on the internet, but I can't tell you the source. But like when people say hurtful things, it's really hard to have a comeback often, because you're just like, did you really say that? But I like this. Epilepsy is just proof of having a brain. What proof do you have? So I thought that was nice. And the little minions for Epilepsy Awareness Month, I also thought was very cute. Now, somebody brought up stigma and epilepsy as one of the challenges to living well with epilepsy. So there are two kinds of stigma. One of them is called externalized stigma, which is when you experience bias from others. Somebody with epilepsy is passed over for the job because they're concerned that, well, what if they have a seizure while they're traveling? How will that reflect our company? And that actually would be a violation of law, but that's an example of bias. An internalized stigma is feeling oneself as if you're not as good. Well, I'd apply for this job promotion, but I just feel like it's taking a risk, or I don't think I'm good enough, or can I handle the challenge, right? It's important to remember that having these experiences is not okay. So if it's others treating you that way or you treating yourself that way, it's not okay, and it's important to talk to the people on your team about it. So for teenagers that might be, well, I wanted to ask this girl to the prom, but I feel like I'm not worthy enough, right? And in my search for Proverbs, I liked this one. The strongest people are not those who show strength in front of us, but those who win battles we know nothing about. And again, this is from Epilepsy Awareness Month. All right. Since I'm keeping this, all my topics are really annoying things with epilepsy, challenges. That's not really about living well. But we have to have a sense of humor about it. We have to recognize that we're all in it there together. And so some aspects about driving and epilepsy. So Pennsylvania is a mandatory reporting state. It's one of the 6 strictest states in the U.S. Some states have no mandatory reporting at all, or actually no requirement. People who have had a seizure and visited an emergency room are likely to be reported without any nuance whatsoever. Immediately after a seizure, right? So if you've, first ever seizure or rarely have a seizure, you go to the emergency room. It's a little discombobulating. You wake up, you're wearing that blue gown, you got an IV in your arm. You may not recall that the emergency room physician told you that you would be reported until you receive that lovely notice from the DMV, right? And so, right, because you weren't remembering things well. And they didn't put it in your, if you've ever been to the emergency room, they give you that piece of paper that has auto printout that makes no sense whatsoever, right? Tells you don't do this, eat well, call 911 for something. And so they often don't realize that they were going to be reported from the DMV until they get a little envelope from them. The other thing that I've seen from emergency room handouts is that people have been told, since they're being discharged, you may resume all normal activities, including driving, even when it was clear that they should not be driving. They're like, well, how could they do that? Because that says this. You're right, it's stupid, and it shouldn't say that. But in any case, in general, the recommendation is if a physician thinks somebody shouldn't be driving, they tell them you shouldn't drive. So many people come to us and they're so upset because they got that letter and they said, nobody told me I shouldn't drive. They probably did, but you couldn't remember. Plus, you couldn't possibly process that because all this other horrible stuff was going on, like you had a seizure, and everybody was very worried that something serious was going on. They have a little website that's in the handout if you need it. Now, in terms of driving and getting around with epilepsy in the state of Pennsylvania, so for some of you this might not meet your specific information. But some seizures meet waiver criteria, so if they're provoked. So if I have somebody who has a inherited, a genetic trait to have epilepsy, and they get a medicine that's known to have lower the seizure threshold. They never had a seizure before. They're probably never going to have one again. They got a very important medicine, but the side effect of that medicine could be a seizure. Then it was a provoked seizure, and if there's a clear explanation to the state can decide to allow them to drive. Other seizures include what they call strictly nocturnal seizures, which are seizures out of sleep. So as long as you stay awake while you're driving, you should be fine. And then seizures I don't make these things up. And seizures that always have an aura, so people who always have a warning that could pull the car over to the side. And then it's important to remember that the citizens of the Commonwealth have the right to appeal. So even if you disagree with your doctor and the DMV, you have the right to appeal, and sometimes people win on appeal. And then in terms of getting that unpleasant notice from the Commonwealth and being totally confused, and many of you have probably gotten them, everybody has trouble processing this bad news, right? It wasn't bad enough that you had a seizure, but you got this letter from them. And even brilliant people have trouble figuring out what the letter wants them to do. So if, in your guidance, teaching other people, I can tell you I have patients who are have PhDs in math and physics and are among the best trained lawyers, and they're like, what does this document say? And some people get a letter, and somewhere in there it says, you can keep the license, but only as a form of identification. Some people are told you must turn in your license right away, and then you have to go to the DMV, and then you can sit in the chair for 3 hours to get a non-driver's ID so you can get on a plane, right? And then some seniors have been told you can keep the license as a form of, but only as a form of identification. So then when the 6 months pass and we tell the state they can drive, they don't go back and get a new license. They have the one that they had before, and they think that that's good until they get pulled over for like a tail light out, and they're told they're driving without a license. It goes on and on and on. So, but if you're confused, it's not because you have epilepsy. Everybody would be confused. Right. She's nodding. Right. It's nothing personal. If you never had a license, you have to be a seizure-free for a year. You have to bring a form to the doctor's office for the doctor to sign in your presence. So you can't just drop it in the mail, which would be nice because you can't drive. So you can imagine, you took the bus with a cranky 2-year-old, and when you get to the doctor's office, the form is on your kitchen table. Right. The form is online from the Commonwealth, assuming their website is working. We actually download some of them. And when I was preparing the slide set, their website was actually offline at that moment. But fortunately, I don't see patients Sunday morning. But it's possible if you forgot the form to pull up the form. In my office, it can take a medical student 2 hours to find the darn thing online, but it's there. Like a medical student, that's like a young person who's brilliant, who has, the brain is working really well. It shouldn't take that long. All right. When you're seizure-free for 6 months, you can call the staff in Harrisburg a few days in advance to tell them to expect your paperwork, and they actually answer the phone, and there's Michelle and there's a Keisha, I don't know all their names. The phone number's right there, the fax number's there. You can let your doctor know at the 6-month point on a Monday through Friday. You don't have to call us Sunday morning at 10 a.m. And then your doctor sends the form back to Harrisburg, and you should have a license back in a day or two. So from this audience, which DMV would you recommend? Any? None. Yes?
I have a question for you. Assuming a person never had a license.
Yes.
They've gone maybe 9 or 10 months without a seizure.
Uh-huh.
They know that when it gets to be a year, they can, assuming it stays that way, they'll be able to get a license.
Mm-hmm.
Can they start the process and get a learner's permit, or do they have to wait a year before they can get a learner's permit?
They have to take the piece of paper to the doctor at the 12 months to get a learner's permit.
Okay, and same as a license. Okay.
Mm-hmm. Learner's
All right,
permit,
thank you.
same thing. At least the DMV in Ardmore is next to a liquor store. I had to take my dad there to renew his non-driver's DMV. We were there like 2 hours. I didn't go into the liquor store. All right. Just very briefly, so we could have a whole talk about the Americans with Disabilities Act and epilepsy, but just as a reminder, it became law in 1990, and it's a civil rights law that prohibits discrimination against individuals with disabilities, including epilepsy. At the time in 1990, because of the historical discrimination against people with epilepsy, no matter what, it would have been included, not just on the nuances of epilepsy, but it would have been included only because of the history of discrimination. But it prohibits disabilities in all aspects of public life, work, school, camp, things that are open to the general public. It was covered under the original ADA, and episodic impairment such as epilepsy is a disability if it substantially limits a major life activity when active, right? So if you didn't take seizure medicine, you would have seizures, and you might need to be accommodated for some other reason, like if you worked as an operating room nurse, you might need a place that was secure to take your medicine on schedule. Right? Whereas for other workers, there might not be a spot to lock up their seizure medicine. So that would be an example of a person with epilepsy who's seizure-free, doing everything, but needs something, a place to put his or her medicine on the job. It's important to remember that, yes, you can go to camp with epilepsy, and if somebody tells your children, grandchildren, or friends that they can't, they can actually be sued. No person who owns, leases, or operates a place of public accommodation can discriminate against an individual on the basis of disability. And for kids who go to summer camps, sleepaway camp, summer camps actually have to be able to give them their epilepsy medication. There's legal ruling in that regard. The Americans with Disabilities Act and the Americans with Disabilities Act Amendment both protect people with epilepsy. And so the second, the ADAA, was an amendment that was very specific to say, even if you haven't had a seizure in 25 years, you still meet the accommodation. So that if you haven't had a seizure in 25 years, but you know that if you had to work a 36-hour shift, you would, you're covered under the ADA. Your employer couldn't make you do that. And so, the EEOC enforces the ADA, which has to do with what things that somebody with epilepsy might need, what an employer can ask about a person with epilepsy. So if you're just applying for a job, they can't ask you about if you have epilepsy, but they can ask you if you are medically able to do the job. And an employer could ask you to get medical clearance or to see a physician, but the employer can't ask you, do you have epilepsy? It is thought that an employer should handle any safety concerns for a person with epilepsy. And no employer should be harassing a person on the job about their epilepsy. And we could spend an hour on this alone, and if we were going to do it again, I would do it with cases, so we'd take you through it. But these are the different websites from the American Epilepsy Society and the EEOC on your handout. Just to remember, if you ask for accommodation in the workplace, you have to disclose your accommodation. So if you say, I can't work 3 12-hour shifts in a row, I need to do 2 12s a day off in another, you need to disclose why. I've been digressing a lot in this discussion, but many times people tell me that they were pressured to leave a job rather than ask for accommodation. And so maybe their manager, let's call her Janice, nothing wrong with the name Janice, but they say, well, Janice said da-da-da-da-da, but Janice actually is not the person who owns the corporation or runs the division, or, maybe they're city or state workers. And they said, well, Janice said, and I'm like, what Janice said is not legal. And in fact, so I hear a lot that people have said, well, my direct supervisor wants me to go quietly. And that's not okay, that's not legal. You can call Sue, right, or Elizabeth, and they'll tell you that. So reasonable requests for somebody with epilepsy include, in any aspect, include saying on the job, having your, would be if you have problems with memory, asking that instructions be written down as well as verbally, right? So, and writing them down yourself, that's a reasonable job accommodation. So, if your boss tends to call and yell at you at 4:45 to say da-da-da-da-da, you know, it's hard to remember when somebody's yelling at you and it's 4:45 and you got to pick up the kids from daycare and you have to take the bus because you don't drive, but it's reasonable to ask that instructions be written down. Shift workers, so that's one of our biggest issues, and actually in healthcare, long shifts in healthcare for me is one of the biggest challenges with my patients, because often they work 3 12-hour shifts, which makes 36 hours. And that's really difficult, especially if they have small children or a new baby. And so to arrive at work at 7 a.m., you got to get up at 5, and then by the time you get home, it's 8. And asking this question, can you be offered a shorter work time? For a number of the people that I look after, they say, you know, if I go to 8-hour shifts, they're actually going to drop my salary a little bit, because there's a premium paid for a lot of healthcare workers if you're doing this other one. But if you need that to keep your job and your benefits and retire at 62 or 65, you might need to do that. A person with epilepsy can be, you know, if you need breaks, you can have breaks. And generally, I prefer that for most of my patients with epilepsy that they work the day shift rather than the night shift. Night shift workers are always more sleep deprived. And then accommodation on the job is needed for women with epilepsy and new babies who are so sleep deprived anyway. And so really putting in a 12-hour shift, I think, is a lot. And so looking for flexible hours as an option in your line of work or working from home. And then the other question that really comes out is, should you tell your coworkers? And in your reading from different resources, you'll find that some people would say yes and some people would say no. But the EEOC in this country kind of recommends that at least one coworker know that you have epilepsy. But some people would say, in my line of work, I would never disclose. And then I think, so, and if I had to say what is an ideal situation, and an ideal situation is having your employer arrange for epilepsy awareness training for your colleagues. And over the years, Sue has done that for me several times, so that that it wasn't the person with epilepsy or their doctor or their family. It was a trained professional who came in and said, this is not the end of the world. If this person has a seizure, this is what you do. These are the guidelines. Let me show it to you. And showing them in a lay person's component was actually really helpful. I thought that this from the United Kingdom, and I tried to make it into a slide, but I lacked the technical skills to do so. But this group called System Concepts from the United Kingdom has this beautiful discussion of an ideal workplace for a person with epilepsy, assuming that there's absolutely no bias whatsoever of employers, and says your employer should understand all the characteristics of your epilepsy and seizure, like how often do you have them? Are they big? Are they small? What is it like? What is your experience like to have a seizure? Just like you would hope that your ideal neurologist would take your epilepsy history. That there would be a safety plan in your workplace in case of a seizure, down to the details of having a safety cord in the bathroom if you had a seizure so you could call for help. The workplace and the work schedule should be developed to minimize triggers, including redesigning your computer and making sure you have a chair that if you had for people who have tonic-clonic seizures, if you had a seizure in your chair at work, you wouldn't fall out of it. I mean, it really did seem like amazing. And dignity, that a person with epilepsy had to have their own locker with a place to lock up their medicine, and a pillow in case they needed to recover from a seizure, and a change of clothes if they needed it. It's down to that level of detail. And an evacuation plan in case of an emergency if a person with epilepsy or other neurological disabilities couldn't get out of the building. And so I thought that that was interesting, not necessarily the US law, but like an ideal sort of guideline. From Canada, you can take these online tutorials even though we're not Canadian, including understanding epilepsy in the workplace and seizure safety. So these are not US law, but they're available, and so you could look at it and say, would I like my boss to do this? We're just talking a little about the workplace and the Americans with Disabilities Act, but remember that this also protects college students. College students who are otherwise seizure-free and doing well as those who need some help, can utilize the Americans with Disabilities Act. It may be an unreasonable expectation for a student with epilepsy to have 3 final exams in a day, right? Other people can do it, but that much sleep deprivation and that much stress might just be too much, and it might be reasonable to accommodate them. And a student with epilepsy might need to take an exam on another day, or just really can't stay. Sometimes college students really don't sleep during finals week, and so we kind of say that that's medically contraindicated for our college students with epilepsy. It's a reasonable accommodation that they shouldn't be that sleep deprived. Does that make sense? Okay. In my personal experience, the faculty at Temple have been kind and happy to help students, and they have really bended over backwards. I've called them personally to say, with my students' permission, to say, I know they haven't talked to you about this, but I do have permission to talk to you, and they're like, no problem. I can give them exam on Thursday, or they were in the emergency room yesterday, whatever. So they've been really helpful. Student health often sometimes asks me, they say, oh, we have a student we enrolled who has epilepsy. Do you want to see them before they start the semester? What do we need to do to keep them healthy? Some college students got a neurologist near the university. And one of the things I see at Temple, I have athletes, and they have, or within the city, I have their trainers, and they may be a care plan because they're going to compete in Georgia on Sunday. And what do they do with traveling with their medicine? So they've been really helpful. This group is actually, we have a transitions workshop, but just remember that going to college with epilepsy is like taking one extra course, so it's one more thing to do. And hopefully high school seniors start taking responsibility for their own medicine before college starts, and parents have to hand over their reins. Those of you who have sent kids off to college, remember like that last year, it was so difficult, even without epilepsy, to be letting go and to realize that they're going to take care of all this on their own, and you just get the bill. And you can see where they are on your cell phone bill and your other things, but they're kind of going off on their own. And some things seem really silly, but like making sure that there's a plan of care to get the medicine to the university. And one thing that I had all these moms doing, they were getting the medicine at their local CVS and then putting it in a FedEx envelope and mailing it to their college student. But actually, in Altoona, in State College, at Ursinus, in Pittsburgh, they have a CVS, they have a Rite Aid, and we can actually route the medicine to go to their pharmacy where they're in school. And if they're doing 90 days, we can actually route it to be delivered to where they're in college, so that mom is not all of a sudden like, oh my God, they're almost out of medicine and they didn't tell me and I got to pick it up and mail to them. So technology is helpful in that way. And even if they lose all their medicine, we can even send like a 10-day supply to wherever it is that they are. Now, they're going to talk a lot about transitioning to college, and we have to talk to the young people about sleep and alcohol. We never condone underage drinking, but our young people need that information. And then we talk about self-efficacy and advocacy and privacy, that we can't, unless we have permission, we can't discuss an adult's medical information with their parents. Once they're 18, they are autonomous. And we have a whole discussion of transition of care, which really refers to the teen transitioning from pediatric epilepsy to adult neurologist. But there is that transition of care, which refers to the young person of taking control of their reins, and parents have to allow that independence. So going back to the alcohol, which is an issue for teenagers, young adults, college students, and everybody, there's some common misconceptions about alcohol. So many people think that seizure medication and alcohol will produce an anti-abuse effect. So I have people, they're guys, they're going to a bachelor party and they're like, I better not take my seizure medicine because I'm going to be drinking. Not true. There's no anti-abuse effect. If you're going drinking, take your seizure medicine anyway. Some advice from different doctors or different people. If you have epilepsy and you take seizure medicine, 1 drink feels like 2, 2 drinks feel like 4. Can make your own interpretation there. I usually tell people that no more than 2 drinks in 24 hours, no more than 5 in a week. So often people say, well, I'm going to an engagement party. What if I have a glass of champagne? You can have a glass of champagne. Nothing bad will happen, but don't drink a lot. And my colleague says for women, no more than 1 drink in an evening, for men, no more than 2. And that's pretty easy to remember, right? Excuses when offered a drink and you don't want one. You can just say, I'm taking medicine, and you don't have to say anything else, right? You don't have to say you have epilepsy. If you're seizure-free and driving, thanks, I'm the designated driver. I'm training for, and you can choose your event, I'm training for getting up tomorrow to watch the Eagles game at 9:30. I'm on a cleanse, right? That's not something I would do, but you just say, I'm on a cleanse of like some peculiar diet of lemon water and chili pepper or anything else you want, kombucha juice. I liked this one. Thanks, but my coordination is bad enough when I'm sober. And my medical student who helped me with my slide set loved this one, and he goes, I already do that. And just get a red Solo cup and carry it around. So for those of you who are older, like you're like, what is the point? But for those of you who are younger, when you go to a party, you're supposed to have a red Solo cup. So my medical student, like when he's Saturday night, he goes to a party, but Sunday he's got to be up at 5 a.m. for his surgery rotation, so he's not drinking. Just get a red Solo cup. He goes, who knew I did that? Yes. Sure. So you could say, I am allergic to alcohol. I have one of those enzyme deficiencies, which people do, that really exists, right? So first of all, they're rude. But second of all, just say, I'm allergic to alcohol. I have one of those enzyme deficiencies. And it would make me very sick. And you could sort of, and you can say, it's not permitted with my medicine, which is not entirely true, but they'll never know. It's not permitted with my medicine. It would make me very sick. And some people with epilepsy know that they cannot drink anymore. It's just off the table. So some people would like to have a glass of wine or a glass of champagne. They could. They would not be sick. But some people, no, can't do it. That door's closed. So just say, it does not mix with my medicine. That's it. It's not exactly true, but it's none of their business, right? Or I have one of those enzyme deficiencies. I'm basically allergic to alcohol. Right? Okay? Okay. Memory is often a problem. There's some things that are really important to remember, like picking up the kids from school or paying your taxes. But a lot of the time, the memory issues can be embarrassing or annoying. But there are workarounds in both your professional life and your family life. And there's some points where you have to be able to remember stuff, right? You have to be able to, if you're a medical student, you have to have a huge amount of verbal memory for stuff. But there are workarounds for memory. And this is also in the slide set. This is from the Epilepsy Organization of the United Kingdom. And so in terms of memory, follow a set routine, right? I always do A, B, C, D. I always hang up my keys right here. Adapt your surroundings. Organize. Put things back in the same place. Get less stuff. Me, I'm like really absent-minded, and generally I have fewer things in my pocketbook, because if I had more, I couldn't find what's in there. But less stuff, less to remember. Use memory aids, and those could be specific to you. Some people would prefer a notebook. Our younger generation would be using a smartphone. If we had an intergenerational epilepsy workshop, we could have the young people teach the old people how to use a smartphone and a tablet, because there are plenty of them who don't, won't, can't, or are so afraid to do it. You can also have somebody in your family. So I have patients where their grandkids set up their electronics to remind it for them, because they would never, even without epilepsy, feel comfortable doing it. Epilepsy-specific apps such as Seizure Tracker are helpful. Mnemonics. So you meet somebody and you pair their name with a word or a phrase to help remember it. That's how we teach half of medical school. The mnemonic for XYZ is remember this. And then it's really important to try and de-stress. So you can't remember anything if you didn't get enough sleep, right? So parents of new kids, you can't remember like anything. Your car keys are in the refrigerator because you're so tired. And you can't remember anything if you're too anxious or upset. And so those are important to remember. But the UK has a really lovely handout. Memory issues in social circumstances. It's not necessary to share that one has epilepsy, but it is helpful to acknowledge something to somebody else. And I'm giving you all these little white lies. I'm sorry, my memory isn't the best, but. So you didn't say you had epilepsy, you just said I have a memory problem. End of discussion. You don't have to say anything else. My ears are not what they used to be. Now, your hearing could be perfectly fine, but your ears were smaller when you were a child. So you haven't said anything. My ears are not what they used to be. Could you repeat that? Or I didn't quite catch that, right? White lie, brain's fine. Forgive me, this is not the best day for my brain. When I have a headache, I'm a little bit fuzzy afterwards. Like, okay, you had a seizure 2 weeks ago and you had a headache then, but nobody needs to know. And finally, just a reminder with epilepsy and memory that and aging, that being well means eating well. And really protecting your brain as you age, which means a heart-healthy diet and keeping blood pressure under control and diabetes under control. And don't smoke, and exercise. And finally, exercise is really important for everybody. And it's important for our physical health, right? Cardiovascular health, reducing risk of heart attack and stroke. But it's also important for bone health, which is an issue for particularly many people. If you have gray hair and you had epilepsy for 25 years, you got some of the seizure medications that weren't so great, so good for reducing our risk of osteoporosis. It's good for balance and reducing our risk of falls, so that's going to be important, when you're 80. It's good for stress reduction, and your exercise program should enable you to turn off the chatter that we all have, not just for having epilepsy, but that we all have, and to de-stress for an hour. So there's a huge difference from doing the treadmill for 40 minutes while you're reading a real estate text so you can pass an exam, and going to yoga class where you're going to turn your head off and you're going to get the wellness aspects. And so exercise should be a time for your physical, emotional, and spiritual well-being. Safety concerns depend on your sport and activity. Carry ID if you run, including a medical alert bracelet, tag, or USB in some cases, although all the young people would run with a cell phone. So they'd have some way of, identifying them there. Wear a helmet when bicycling. Never swim alone. Complete the safety information on health intake form at the gym. Stay hydrated, and in terms of exercise supplements, be careful because some of them contain things that can lower the seizure threshold. So don't buy or take weird stuff from the GNC. Don't take stuff that has stimulants or show your doctor this is what I'm thinking of taking. Sleep, get enough. Lack of sleep worsens seizure control and worsens memory. Not enough sleep makes everything more difficult, as anybody who's ever had children knows. If you're a parent of a young adult, and you see an Uber charge at 1 a.m., don't be annoyed. Be glad they went home safely, right? And academic schedules can be tailored so young people get enough sleep. Parents, both men and women with newborns, need enough sleep. So sometimes that means that, your mother-in-law or your sister-in-law that you really don't like, but who will take the baby, you need to let them take the baby so you can get enough sleep. Put away the electronics before you go to bed and consider reading on paper rather than a tablet, or reduce the light. Will help you with sleep. And everybody doesn't sleep as well when you're more than 40, so you can't, that's why they say you can't burn the candle at both ends anymore, and it's because you lose some of your slow wave sleep. Sleep is more fragile. That happens to everybody, not just if you have epilepsy. Epilepsy and depression. 1/3 of people with epilepsy will suffer with depression, and it can impact anyone, and it bears stigma. This is does anybody not recognize Prince Harry? Okay. And so both Harry and William have been really active in depression and the fight against mental illness in Great Britain. Their charity is called Heads Together. And with William, he's really been focusing on suicide prevention in men. And they've talked about the fact that their mother suffered with depression, and after her death, like as you would expect, they did as well. And to quote Prince Harry, the experience I've had is that once you start talking about it, you realize that you're part of a big club. And so if you're depressed and you have epilepsy, you now have two problems, and both of those problems together make it hard to sleep and remember anything. There are many different resources for help. Spirituality, your religious community can be part of a support network. And not to promote Greenwich Bioscience, but they had all these incredible inspirational stories on epilepsy.com. If you decide to read them, they're very inspirational, but please get a Kleenex box because I thought that they were really emotionally provocative. You can find support on your community or online, and so obviously we have our local epilepsy foundation here, the National Epilepsy Foundation, CURE. Seizure Tracker is another place, and the North American Pregnancy Registry, so you can find support online and information. When we think about going online, there are two things. One, support. Two, medical information. Those are slightly different. So I want to learn about this drug versus I really just need to talk to people about what it's like to have a child with epilepsy who's had a seizure every month for the last year, right? Those are kind of two different things. And in terms of self-management, there isn't that much specific to the neurological literature at all, but online investigation of a disease helps people gain autonomy, gain control, connect with others, and it makes something scary a little less scary. One concern that doctors have is that people who go online try and get medical information, and the medical information isn't specific enough to help them make medical decisions. Where there is actually information, which is the GI literature, inflammatory bowel disease, they actually found that when people start playing Google Doctor, it doesn't actually harm them. So people who look up stuff on the internet generally bring it back to their doctor, and they do make an informed choice. They might annoy their doctors when they come in and they got a 26-page spreadsheet for a 12-minute visit, but in the end, the patient who is Dr. Google can still make the best decisions once that person meets with their physician. Online support groups, this group would know this, but doctors don't always recognize it. They're social ties forged on online spaces and provide the basis for an individual to get self-management, to figure out how to cope. And they're altruistic. The people who do it, with no expectation of help in return. They offer something. Hey, I found that this was the best place to get X, Y, Z. So that's community that is often lacking and can be very helpful. Technology in epilepsy is an emerging thing and can really be helpful, but you have to be comfortable with technology. It's easier to connect to the epilepsy community if you use the internet. Smartphones, tablets, and computers are helpful. So this group mostly uses the internet, but there's a huge epilepsy community that doesn't. This is an example of a seizure tracker watch that we're using. And there are other smart monitors, including an Apple Watch. There's other technology that's out there. And in closing, I'd just like to remind you that some people are just born fabulous. And this is a slide from the Epilepsy Foundation from their Instagram site. So things to give yourself. Credit. I'm actually pretty awesome. A break. Time to accomplish your things. Permission to make mistakes and forgiveness when you do. A pep talk and grace. Thank you.